Hello, everyone. Welcome to White Coat Blueprint. I'm Sai, your host for today, and I'm excited to be joined by Dr. Adam Rosenbloom. So, hi, Dr. Rosenbloom. How are you?
Good, happy to be here.
So, Dr. Rosenbloom, to get us started, could you tell us a little bit about yourself and what you do?
Sure. I am a pediatrician. I'm what's called a complex care pediatrician, which is kind of like a newer specialty in pediatrics. We are a primary care provider for children that we call have medical complexity, or children that have special needs or special healthcare needs. I've worked at the Children's Comprehensive Care Clinic, a medical home for children with medical complexity, for the last 15 years. Here in Austin, Texas, we are affiliated with Dell Children's Medical Center.
Thank you so much for sharing that. And I'm just a little curious. So, what drew you to treating medically complex children? And what made you choose this pediatric path?
Sure. So, one of the interesting things about medical school is you really get an exposure to all different types of medicine. You learn out of a book and in the hospital and clinics, really a lot of the different things that doctors do. And so I got exposed to lots of different things in my practicums at medical school, and begun to be drawn to pediatrics when I did my first rotation in pediatrics in my third year of medical school. Um, I loved working with children. I really loved the environment of the culture of caring for children. Um, I found it just has a different feel of caring for children and caring for the families that care for children. Um, it's nothing against caring for adults or caring for the elderly, but there is a feeling of care and an empathy and concern for the experience of a child when they are ill. Um, there's something called child life, which is an entire specialty of professionals who focus on comfort and and experience of children when they are ill. And you walk into a children's hospital, it's bright. There are colorful things on the walls. Uh, it is. It's an atmosphere that I was just drawn to, and I was drawn to the kinds of people that are attracted to that specialty, and so we gather together and pick a like-minded specialty together, and so we create a culture together of individuals that I think uh, are similar. And I just liked the culture of pediatrics, and so I really started to be drawn towards pediatrics and decided to do my residency in pediatrics here in Austin, Texas. And in between my undergraduate degree and medical school, I also got a master's in public health, where
Oh,
you learn about the way that systems of care are organized and the ways in which health is influenced not just by our diet and medicine and the one-on-one experiences, but the way that systems are built and environments are built and the way that those affect individuals. Um, and so when I started to do a rotation in pediatrics, similar to medical school, you get exposed to all different types of pediatrics. I did a rotation at the complex care clinic here in Austin during my residency. First, I was drawn to the people uh, that having a mentor, having an inspiring medical director and boss, and Dr. Rahel Barhani, who founded this clinic, was one of the big draws. But I got really drawn to this idea of complex care because it is about caring for children with medical complexity, so lots of medical problems needing the help of technology like feeding tubes and breathing tubes, taking lots of different medicines. the medicine itself is interesting, it because it is the kinds of things we learn about in the textbooks, but it is also very much a care that is influenced by what we call systems-based practices, the way that a system is built to care for children like this, the way that individuals need to work together, that the problems are complex. So we need the input of multiple different kinds of people, different medical teams, different other paraprofessionals like home health nurses and therapists and teachers. Um, and I saw how I could use what I had learned in public health school to also really help affect the way that a system is organized and designed to help children and families like this. And so I can kind of put both of these two interests together. Um, but now that I've done this job for 15 years, the thing that really attracts me to it is the relationship. The,
Absolutely.
yeah, you know, there are different kinds of doctors that see patients for a very short period of time, maybe in an emergency room or in the hospital for what we call an episode of care. But primary care is care over a long period of time. And it is about building relationships and trust and being there for families when their children are well and they are making great milestones, graduating from elementary school, taking their first steps, getting dressed up for a party, and when they are very sick, at their bedside in the intensive care unit, not knowing if we can make it through the night, and during end of life care, when children die and their families um, are mourning the loss of their child and they are celebrating their life at a funeral with their family and community, and I get to be a part of all of that. And there's not a lot of medicine left that you get to really have these kinds of really deep, meaningful relationships with people over a long period of time. And that's the thing that draws me to it now because I find it extraordinarily rewarding.
Absolutely. I think when it comes to caring for medically complex children, I feel like the job is extremely stressful, but at the same time, it's so impactful and important. And I think I imagine that the most rewarding part of your job must be seeing these kids and their family walk out of the hospital happy and healthy, and to see them, live their life. There's so much more to face in life, and to see them grow up and be healthy. I think that's the most rewarding part. In your personal experience, could you share us some moments that you have experienced like that?
Yeah. Well, one of the interesting things about our clinic is that we are co-located on the campus of what's called the Rosedale School, which is the Austin Independent School District's public school from kindergarten to age 22, really designed exclusively for children with medical and behavioral needs. We are on their campus. And every morning I go into my break room and make my coffee and look out the window, which looks out over one of the outdoor playgrounds. And I watch my patients playing on a playground. And it's one of the best parts of my day is to get to see my patients out there in what I call their natural environment. And and this is an extraordinary school that I think really supports these children and these families. But that's one of the things that I love every day is to get to see my families well. Being a parent that cares for a child with special healthcare needs is very stressful. It's a full-time job.
Absolutely.
It's 24/7. It's a physical job. It's an emotional job. Um, and when their children are sick, these families are under an extraordinary amount of stress. And when they are in the intensive care unit and their child is sedated and intubated, it's we sometimes lose sight of uh, what is the potential of these children? What are they like when they're at their best? And really, what are these families like when they're at their best? These are extraordinary families, and when they are having just a regular, what we call a whole child checkup, when their child is not ill, when we get to really um, not be under stress, we get to have big conversations about the meaning of this child's life, um, and those are extraordinary experiences to get to really make space for with these families. That out of all of the doctors that get to see these children, I'm one of the few that gets to see these families and these children at their best. Um, it's it's crazy to say, but one of the things that I actually find deeply meaningful about my job is to go to funerals where a child has died and we are celebrating a child's life. And it's oftentimes during those experiences when the true meaning of a child's life, the meaningful impact that this child had on their family and their community is really shared. You know, people they get up and speak about these children. And, I recently went to a funeral of a 4-year-old boy who was nonverbal. Um, and and one of his aunts got up and said that this child saved her life. That when she was at her lowest, this child's, courage, bravery, uh, showing the just the significance of a life. And that effect on her, she said, really, brought her out of a dark place and gave her the strength to carry on with her troubles. And I think, you go to a funeral for somebody who is old, and we often, talk about all the things that this old person did in their life, all of their accomplishments. There are a lot of children whose accomplishments that I see at their funerals are things that we take for granted, like walking and talking and getting to go to school and having a quinceanera. Um, but it brings back this idea that the meaning of life is maybe not necessarily all the things that we do, but that there is an inherent value to life in and of itself, and that's one of the most meaningful, deep and special moments that I get as part of my job is to get to be a part of those experiences and those spaces.
That's actually really beautiful. Thank you so much for sharing that. There is nothing more painful than to watch your own kid suffer and, to lose them at such a
Yeah,
young age, especially because I'm pretty sure parents have their own dreams, their own wishes for their children. They want them to live a long, happy, healthy life.
right.
And seeing them struggle in hospital itself will take a toss on them emotionally, and it'll definitely increase their stress levels like crazy. And I think
Yeah.
you're doing an amazing job standing close to them and helping them out during the hardest moments, and being present is more important. And thank you so much for always being there with your patients, Dr. Rosenbloom. I think
Yeah.
you're doing an amazing job.
Yeah.
Thanks a lot for that.
I think especially as we enter maybe a new era of technology being even a bigger part of medical care, thinking about chatbots and AI and Googling our healthcare. I think if you ask a lot of people what they want out of healthcare, people will say that they want a human relationship. They just want somebody who knows them, who knows who they are, who knows their story. A lot of these families carry a heavy burden of carrying a story, a narrative of all the things that there are to remember about a child's medical care. Um, And when you ask the parents that care for children with these very complicated medical issues, the thing that they say that they want is just somebody who knows them and that they can call that person when they need them to help them solve their problems. That relationship that they've built over time and with knowledge and care is accessible to them when they need it. It's simple, actually. We add a lot of layers to the healthcare system to try to make healthcare better. But at its core, what people want is a human relationship with somebody who knows them, and that can help them solve their problems when they need them. And so, um, we at our clinic have tried to build a system that makes that possible. Um, and it it's the way that medicine used to be. We talk about the country doctor, the doctor from cradle to grave, that was part of a community, that knew a family, that was able to come to their home when they needed them, and was able to help them navigate a system of people who didn't know them and didn't and can be a bridge to help transfer that trust and relationship to the subspecialists that when they needed more care. And it's a human response. And as we build systems that outsource that relationship to a call center in a different state, or we invest in systems that are not at the ground level for things like population-based health and research and quality improvement, or we outsource a relationship to a chatbot or AI, we lose a real fundamental part of the way that medicine has worked for hundreds of years, which is uh, a human relationship of somebody that knows them, that's accessible to them when they need them.
Absolutely. Thank you so much. And I think at any point of time, human, like emotional connect, like a connect on on emotional basis is something that patients always look forward to in healthcare. And a lot of people, like us in uh, it's just more than just help. People come to doctors for treatment, but also for emotional support. They're going through a lot, and I think it's really important to stand by them and help them out during their most toughest phase of life.
Yeah.
So I think that way of care providing is really important. That's also another very important aspect, and I'm really glad that hospitals and clinics are focusing on that as well. And it's truly incredible to hear that from you, Dr. Rosenbloom. Thank you so much for
Hmm.
sharing that.
You bet.
And also, I have a question for you. So, when you are treating medically complex children, how do you interact with parents when you're telling them, that your kid might not, live for too long, or they're going through something really hard? How is it like, and how do you emotionally support them, and how does it go?
Right. It goes in a lot of different ways, and it doesn't always happen all at once. Um, we get a lot of good training in residency, and then as I've continued to practice from my colleagues about how to have what we call difficult conversations. Um, and this is sort of part of a whole subspecialty called palliative care. There's a kind of medicine where the job is to have these kinds of difficult conversations, to share news, to understand where a family is in the process of grief, and helping them make informed decisions. Um, and we think about medicine as the pathophysiology, the way that the body works and the way that the body can go wrong. And we learn about medicine, which is the interventions that we can use to try to help change the way that the body works to help it heal. And in palliative care, our our understanding of things like grief and stress and decision making is the way that we understand the way that the body works, just like pathophysiology. And our words and the way that we deliver those words in the spaces that we make, in the tone that we use, in the cadence, um, in the way that we speak is our medicine. It's our biggest intervention. Um, and we think of it that way, that we approach it that way. Um, we um, we learn tools. We learn what kind of medicine we have in our medicine case, and the different kinds of medicine, and the different times at which the different kinds of medicine is appropriate. And so we learn about active listening. We learn about the words that we use and the words that we don't use, um, and when's the appropriate time to use those words. And so it looks in a lot of different ways, depending on a situation. Just like depending on what the disease we're treating, would we choose the right medicine? But we get training for it, and we practice it. We have what are called sort of mock conversations. We have actors. I just took part in training of our residents, which are the doctor trainees after medical school, our pediatric residents, um, where we had a couple of sessions where we split into small groups and we give a scenario and we have a parent um, we have an actor who plays a parent. It was oftentimes me, and we practice using the words and the way that we deliver them. And then we stop and we debrief and we make comments about what are the things we noticed that maybe even the person kind of doing um, the training may have not noticed about themselves, maybe the way that they delivered something and the way that it came off. And then we practice it again, just like we do with medicine, just like a surgeon would practice a surgery maybe on a cadaver before they practice it on a real patient. Um, we do that. We approach it in sort of a professional, technical way, just in the way that we use our words. Um, and so there's lots of things about about how to have those conversations that I can share about the way that they go. Um, but they go in a lot of different ways, and
It
sometimes
surely
they,
must be emotional.
yeah,
It surely must be emotional.
my job is not like uh on the like the pit where it is stressful in that way. It's not often uh high intensity, paced. Um, it's often much more slower than that, which is what I like about my job too. It's about having um, space for deeper conversations. And so I say that my job is not necessarily about a high stress or physical labor kind of stress, but it is an emotional labor. Um, and that is a kind of stress that comes up in a different way. What it is like to bear witness to other people's trauma and grief. Um, and so we talk a lot about in our work about self-care and processing our own emotions as we bear witness to other people's suffering. And so I do a lot of things to help make sure that my mental health is in a place where I can be available to help others.
I think protecting your peace and your mental health is really important, but but then you're working with kids, and kids get emotionally attached very easily, and it's you would unnoticingly get emotionally attached with them as well. And if something unfortunate happens to them, and it'll be just a lot of pain. Have you ever experienced that? at
Yeah, I
least in
think
your early
Uh,
times?
I think that one of the protective mechanisms that people who work in stressful jobs do to protect themselves is that they might um, disconnect, or they might dissociate, or they might um, try to be stoic or not feel. Uh, and I don't necessarily think that's an approach, and sometimes that's uh, important, and sometimes we do have to do things to protect ourselves. But I think that there's nothing wrong with feeling in our job. I don't think there's anything wrong with getting attached to people, because my job is about building relationships. And so I build relationships with people, and I know them, and I know their names, and I know their stories. And when those relationships end, like at a funeral, when a child dies, and this is really the end of our relationship, at least in the way that it has been, I also feel grief. I feel grief for the loss of my patients. I cry. I cry at funerals. I cry at the bedside of a child who we are withdrawing care in the intensive care unit. Um, I think it's okay to show emotion. I think it's because we are human, and it's okay to be human. And I think that being human is an important part of our job. Um, you know, we, the people might debate me on that. And in order to do
I agree.
a stressful job, you have to, um, people who work in an intensive care unit where people die all the time. Um, you do have to find a way after one of your patients dies to remember that you have six other patients in the unit that you still have to care for. Um, and that you do have to find a way to pick yourself up and continue to do your job. But I think it's okay to tell your colleagues, hey, I need to go for a walk. I need to go outside for 30 minutes and recollect myself. And hopefully, we build systems that allow for that. I think that we have to build systems that recognize that we do a lot of emotional labor at our jobs. And if we don't process it and we stuff it down, then it becomes a problem. Then we go home and we, you know, take it out on on our families, right? And so, but I don't think that that means that we have to, stuff it down and protect ourselves. I think we just have to do the work of caring for ourselves while still remaining human.
Yeah, I think being expressive is very important, and you're working with kids, obviously, and they're under a lot of pain. And the least you can do is gain their trust and make them feel comfortable during their stay. And I think to gain someone's trust, you should definitely be emotionally close to them at some point or the other. And I think it matters really a lot, because to to help you need to gain their trust, and that's definitely really important. Thank you
Yeah,
so
and
much for sharing that.
a big part of gaining people's trust is convincing people that you care about them. Um,
Absolutely.
and we can show that we care about people in different ways. Um, but I think one of them is to be emotionally available. And um, I don't think there's anything wrong with sharing that part of yourself with people.
Yeah, and you also mentioned the fact that sometimes you just need to tell people that you have to take a walk, or to get a little break. You said
Yeah.
that you cry at funerals. I think we're all humans, and it's very important to express and let our emotions out, for our own mental health, for the
Yeah.
betterment of our mental health. And yeah, it's good to be expressive. It's good to share grief, and at some point you just need to let it go. and instead of locking it in and keeping it in, because
Right.
that's gonna add up into something very big, something that we might not know, but it'll be coming.
Yeah.
So thanks for sharing that. And I just wonder, when a patient walks in, how do you diagnose them? So you and your team, how do you interact with the patient, and how does it go? How does the first interaction go? Because I know when patients walk in, they have multiple underlying conditions and
Right.
multiple symptoms. So, and they're very sick, obviously. So how does it go?
hmm many times when a patient comes to our clinic, they've already had um, a big diagnosis already given to them. Something has happened prenatally or during birth or potentially during a big accident. Um, there are oftentimes a lot of things that we already know about them by reading what the other doctors have written about them, and the big diagnostic workups of finding out sort of what are the problems in a child are done typically like in a big academic center in a hospital with big machines and blood tests and things like that. Um, and we are mostly what we call a chronic disease manager. These are children that sort of never get better, but we help them try to manage their ongoing chronic issues. And so there are new issues that arise, and we, talk to families about what's been happening at home and try to figure out why it's happening. And this is something that you'll learn about in medical school about how to do this, how to come up with a list of all the things it could be and a plan to try to figure out which one it is. Um, and then there are times where we don't know what's going on, where we don't have the information or the right tests to be able to diagnose something. And sometimes we don't have the answers. Sometimes there are mysteries, and sometimes we have to sort of live in a space of unknown, which is difficult for a family for sure, especially when it's the hope that if we know what is the problem, we can come up with a solution, but also for a doctor whose training is about solving problems, about recognizing and treating. And sometimes we're unable to do that. Sometimes we have intractable problems. Sometimes we have problems that we can't fix. Most of the time, I would say, in my clinic, we have problems that are intractable. Um, and so we have to learn how to sit in a space of uncertainty and sometimes feel helpless that we can't solve some problems. And so we find a way to manage them. We try to find a way to make things as good as we can. Um, and we learn how to sit in that space with a family that is a very difficult space to be in.
I think you just shared a very important fact, because, students who want to go into medicine, what they usually think is that, at least for me, medicine is always about saving lives. But the truth is, it's not really just that. It's about, you know, being with your patient and sometimes saying goodbye to them and being there for them during their final moments and making them feel happy. I think to provide that comfort, it just takes another level of patience and attention and passion, I'd say.
Yeah. Yeah.
Um, and I just wonder. So when these kids, when they grow up, when like, as in they go through the treatment
hmm
plan, and they're doing well. And so if they eventually transition into an adult healthcare system, how does
Yeah.
that go? How is the transition like for them and for the family, and how do you deal with it?
Yeah. So I will say it's one of the most difficult parts of our job because we have spent a lot of time designing a healthcare system that we think is responsive to the needs of these families and these children. Um, this thing that we were talking about building a system that focuses on human relationships and access to be able to solve those kinds of problems. And there's not really a great a counterpart in the adult world, at least not here in Austin, Texas. There is not an adult complex care program. There are some programs that the idea of complex care in pediatrics kind of drew upon. One is geriatrics, which is a similar kind of approach, which is this understanding of a sort of a palliative approach, a chronic disease management approach, a medical home approach, meaning that you have a home base. You have somebody who knows you, who can help you navigate a system that can be available to you, um, that can coordinate care among multiple different teams and subspecialists. So there are, I should say, there are some models in the adult world that are designed to help adults with medical complexity. Um, but for the kinds of patients that we care for, there aren't great systems right now, at least in Austin, Texas. There are some in other parts of the country that have recognized that adults with pediatric onset diseases need something different than potentially what the adult healthcare system can offer currently. And there's been an interesting trend, actually, of pediatricians kind of taking more ownership in diseases of pediatric onset. So, like for example, cystic fibrosis, which is a lung disease. It's a multi-system disease, but one of the big systems is lung. And so oftentimes pulmonologists, pediatric pulmonologists, are the doctors that care for children with cystic fibrosis. And it's a multidisciplinary approach that includes a nutritionist, sometimes an endocrinologist, a social worker. There's multiple different people that so the care was sort of designed where you would have a cystic fibrosis clinic where somebody would come and get all the kind of care that they needed for that disease in the pediatric world. And for a long time, cystic fibrosis was such a severe disease that a lot of children didn't really survive very much to adulthood. And so adult pulmonologists and adult uh, providers weren't very familiar with caring for adults with cystic fibrosis. But remarkably, especially in the last 10 years, we've had some huge advancements in gene therapy and medications that treat cystic fibrosis in a much better way, and a lot more people are surviving to adulthood. And there's been a trend where those adults just continue to see their pediatric subspecialty group. It's the same with congenital heart disease. We have adults going to pediatric hospitals to get follow up for their congenital or pediatric onset congenital heart disease um, because adult cardiothoracic surgery is sort of a completely different, it has a completely different set of problems. And the adult cardiothoracic surgeons just aren't as familiar with caring for congenital heart disease. And so the pediatric subspecialists continue to see the adults throughout their lives. And so, we begin to wonder, why are we transitioning these patients to an adult system? Why don't we just continue to follow them? And so, I have some patients who are 22, 23, 24 years old. Um, I, it, it's the thing that I am worst at my job is discharging patients to an adult provider because um, there is a bit of a cliff that families and children, or adults, I should say, fall off of when they move to an adult world. Um, but it's not just the subspecialists and the doctors and the training and the medicine, but it's the system. It's the way that insurance is designed, the way that public insurance transitions from a pediatric to an adult public insurance, and so less things are paid for, things like therapy and home health services um, are uh, are not as paid for as in the pediatric population. Um, so these are the kinds of things that we talk about it's not just the pathophysiology and the medicine, but it's the way that systems are designed to care for adults like this. And so I think one huge project that I would love to be involved in is to try to build a system like that in the adult world. It's difficult because I don't live in the adult world. I live in the pediatric world with my pediatrician colleagues in my children's hospital, and I don't have any relationship with adult providers and the adult hospital administrators. So I need partners in the adult world to take this on. And there's unfortunate research about how difficult it is for adults, like the ones that we care for, and their ability to access care. And it can be just the little things. Like, for example, a lot of the children that we care for are wheelchair dependent. And if you want to manage their nutrition, you need a wheelchair scale in your clinic, an ability to get an accurate weight, and you need a handicap accessible space, which doesn't which there's ADA compliant handicap accessible spaces with a ramp or an elevator or a wide door, but it's also an adult size changing table in a bathroom. It is a Hoyer lift to help pick up and transfer patients from a wheelchair to a bed. It is there's a lot of things that go into building a space that can actually care for adults with disabilities that not all medical spaces in the adult world have. And so it's a lot to think about, but it's a big project. And the better our medicine gets, the more children we care for survive to adulthood, the more that we need to think about how to build a system that cares for these adults.
Absolutely. Thank you so much. And do you see these changes coming up, or do you think it'll take more time for them to be incorporated?
Yeah, so there are certain programs around the country that do a better job of this. I know Baylor School of Medicine in Houston has a program where they have an adults with medical complexity clinic. I believe we've had some pediatricians here in Austin that have trained in that program. There's a specialty in medicine called MedPeds, which is a combined residency program where you get your residency in pediatrics and internal medicine. Um, and honestly, this is or should be what that subspecialty is really built for. In my experience, a lot of people that go into med peds end up just choosing one or the other. They just end up being either a pediatrician or an internal medicine doc. They don't necessarily do the big things that bridge the two. Um, but this is actually the I think the reason why there should be a med peds program is caring for adults with pediatric onset diseases. And, in certain big academic centers where there is potentially better funding or better interest from a community minded administration to build a program like this. Um, but there are lots of places in the country that don't have a system set up. Rural areas of most of the country, and in even some big city centers, there isn't necessarily programs like this. So it's a big need. It's a big thing that this country needs. And do I see it happening? Maybe not enough.
Oh, um, I genuinely don't know what to say except that I just feel really, really bad. And I really hope that, there's a lot of change in pediatric healthcare, and I hope there are more specialists and more improvements that are made to facilitate, more facilities that are there for these kind of kids. And I really hope for the best. And I think everything will click soon, you know? Yeah,
Yeah.
I think
I think it's more work to be done, and it's the reason why there are people like you in the next generation that can hopefully continue to, you know, work
absolutely, absolutely
on
looking
these
forward to it
problems.
actually. Yeah.
Hmm.
Thank you so much for joining us today. I learned a lot. I had a lot of important takeaways. I hope the viewers also found this very interesting. Thanks a lot, Dr. Rosenbloom. I had an amazing time with you.
You bet.
And
Happy to.
yeah, thank you so much.